Thank you, Sarah. Okay, so we've got feel good. We've got a lower maternal pulse. Why would anybody get into a bath while they're in labour? Less pain? Ah, someone's been in Marilyn's session. Marilyn spoke about environments and uh, bound environments and unbound environments, and how women feel safe in an environment that's bound. And yes, baths often provide that kind of environment, don't they? Stimulates the parasympathetic nervous system. Less pressure, sense of weightlessness. Yeah, great. No one can touch you. Yeah, that's another point that Marilyn raised about women in baths. They're in there a more private space. People don't have access to them. Increases contractions. Great, Eva. Thanks. Okay, so there are a few relaxing. Yep, exactly. We have lots of ideas, don't we, about water immersion and its benefits, and some experience, of course. So these are the proposed benefits that you've touched on as well. Warm water promotes relaxation, and many of us will enjoy a bath with or without labour. Take a good book into a bath, or just have a relaxation there. So we know from experience it can be quite relaxing. Decrease in stress hormones, therefore we've got more oxytocin, more coordinated and effective contractions. The buoyancy gives us a bit more freedom of movement, especially if it's a bigger kind of bath. It makes it easier to maintain certain positions like squatting, which could be quite hard on the knees. Decreased pressure on the vena cava. Warm water provides pain relief, promotes relaxation of the pelvic floor and the perineal tissues, therefore an easier birth. It encourages that hands-off approach to care, as Sarah pointed to. So less interventions. It's a bit more gentle for the baby and provides women with their own space and control. So these are the proposed benefits. I'm not saying that these are evidence-based benefits. This is kind of what we think. So let's have a look at the evidence. So Waterbirth and the neonate, babies, we're talking now about babies born underwater. It's really important when you look at the evidence and practice to distinguish from when somebody is using water immersion for the first stage of labour and when a baby is born underwater, because they're obviously quite different things. Some women will do the first but not the second, and some women will do both. Most of the concerns raised are really from the perspective of the neonate, and they come mainly from case reports. And a case report it might be a piece in a journal or shared at a meeting of at one situation that happened with one baby or one woman, so a case study, if you like. There's concern about neonatal respiratory distress, about neonatal infection, about water aspiration, umbilical cord avulsion or snapping, and that picture there is of a cord avulsion, so the cord has snapped. Hyponatremia, so that's low sodium, and the mechanism for that, the theoretical concern is that the babies are swallowing so much water that they become, it dilutes the sodium in their body. Lack of oxygen resulting in hypoxic ischemic encephalopathy, and neonatal thermoregulation, so the baby's ability to maintain its temperature in this environment. These are the concerns, but let's have a look at the evidence for them. So there was a Cochrane review of maternal outcomes following water immersion in labour, and you can imagine how enormously difficult it is to do a randomised randomised controlled trial on something like Waterbirth, because to do that you'd have to have women agree that they would be happy to go in the control or the intervention group, which would be the Waterbirth or the land birth group. And at some point, I don't know when, you'd have to direct her if she chose to be, if she agreed to be in the trial and she randomly got given the Waterbirth one, you'd have to direct her to get in the bath, pretty much like it or not, because that was the group that she was randomly allocated to. So there aren't a lot of women who are that ambivalent about Waterbirth that they would agree to be randomly allocated to one group. So there are very few women in this study. I'll show you the numbers in a moment. So a Cochrane review, as you know, pulls together evidence from a number of different trials and puts them together and reanalyzes them. But there are very few trials that they were able to pull together here. But the upshot is, and it is the best level of evidence that you can have for something like Waterbirth, that it decreased the rate of epidural and spinal anaesthetic. This was also this review was also looking at water immersion just in first stage as well as Waterbirth. It was doing both things. So we can definitely say that there was only just less epidural and spinal anaesthetic in the women who used water immersion. So it is a good pain relief option. It also decreased the duration of the first stage of labour. So Eva, who said that the proposed benefit was increasing contractions, yes, it does. Or they're more effective contractions because that first stage of labour was reduced by about half an hour. It reduced women's self-report of moderate to severe pain very significantly. So it's a really powerful pain relieving mechanism. In terms of difference in narcotic analgesia, there was no difference. There's no difference in assisted modes of birth following water immersion or caesarean section or oxytocin, no difference in rates of perineal trauma and no differences in maternal infection. So they're the outcomes that they could measure from evidence from randomised controlled trials. So their conclusions: there's evidence that water immersion during the first stage of labour reduces the use of analgesia and reported maternal pain without any adverse outcomes on labour duration, operative delivery, neonatal outcomes. There wasn't enough information about the third stage of labour in water. So there's only one small trial that looked at that aspect. So the best quality evidence we've got doesn't show any ill effects from Waterbirth, but they are very small trials and probably not enough that focus on birth in water. So recently one of my honours students did a study on, it was a systematic review, but it didn't just look at randomised controlled trials because there were so few of those that gave us any good numbers. She included observational studies as well. So they're studies where you're not requiring women to do something or not. They're having a water birth because they want to have a water birth, but then you're gathering up the data on the outcomes of those water births and comparing them with similar women who are having their babies not in water, usually at the same facility. So they're not as high a level evidence on the evidence hierarchy. They kind of come in about second. So that was Rowena Davies, and I'm presenting her honours work here. So this is going to sum up the evidence on the next level of evidence, including the RCTs, and it's probably about the strongest evidence that we've got at the moment on Waterbirth. This is published in the JBI database of systematic reviews, and I have in ResearchGate popped a version of it there as well because it can be a little bit hard to get through the JBI. So we were focusing here on outcomes for neonates as well, because that's where most of the criticism comes and where most of the concern comes. So we wanted to look at the best available evidence relating to the effect of water birth compared to land birth on the mortality and morbidity of neonates, and we're focusing just on low-risk women in the care of qualified midwives or health professionals, usually they're midwives. So we did a very thorough search of all the studies we could find, and we got down in the end to 12 studies that were included in the analysis of the data. And we were looking for all these outcomes in the list, but the literature only gave us data on the outcomes with the tick. So we didn't find any that were measuring hyponatremia. We didn't find any that had cord avulsion in them, HIE or birth injury per se. But all those other outcomes we've got some information on. The interesting, we'll see in a moment when we go through. So these are the studies. You can see the 2 RCTs that were included in the randomised control trial was by Woodward. Had 60 people in the sample, and Nicodem was an RCT from, I think that was from South Africa. So they were in the Cochrane review. So the other studies listed below those are the ones that we've included. There are a couple of prospective cohort studies where they enroll people into the trial when they're still pregnant, and then they follow them forward and collect data on the water births and the land births. There's retrospective cohort where they just go into a database and pull out on the ones that have had water births and land births and make comparisons there. And there's some case controls. So in those studies, they pick an outcome like some sort of neonatal outcome and a bad case usually, and then they compare with how many of those sort of cases are in water birth and in land birth. One of the really good studies, which I haven't seen, the Giesbühler one, if you can see in the mustard colour, 2004 from Switzerland. It's a prospective cohort study, and it had 9,500 women in that study, so it's quite a strong piece of work, and it was a thesis that we were able to find, and she did a lovely piece of work there. And I haven't necessarily, we weren't able to find any other publications on that. I don't know why she didn't publish in any journals. Just a picture for some light relief. So from the analysis, and if you're interested in the forest plots and tables and more detail, I can provide that to you, but I'm just summing it up for you here. This is really, I think, the best evidence that we've got around water birth at the moment, coming from RCTs and observational studies. So there's no difference in rates of neonatal mortality. But as you know, you do need very large sample sizes to be able to show a difference in this outcome, because it's quite rare. But in the data we've got at the moment, there's no difference. There's no difference in neonatal resuscitation, the degrees to which babies need to be resuscitated with land birth or water birth. There's no difference at all. There's no difference in respiratory distress syndrome within 24 hours of birth, or in neonatal sepsis infection within 7 days of birth. APGAR scores are interesting because people collect these in different ways, and you can see some have got APGAR score less than 7, some have got less than equal to 7, and I wish that we could have some agreement about what that outcome might be, so we can do that consistently. So we could only analyse them separately. We did find that the APGAR score at less than 7 at 1 minute, was increased with water birth. So about twice, water birth babies had twice the rate of an APGAR score of less than 7 at 1 minute. And I don't think that's unusual at all, because if anybody's attended a water birth, you'll see that those babies do not pink up as rapidly as you would note in a baby born on land. And I think it's because of the lack of stimulation. It's not necessarily a problem, because they've usually got a good heart rate, and you can see that they don't need more resuscitation. But I think in our evaluation, we're scoring them lower because they tend not to pink up, and they might not seem to be have as much tone as babies born on land. So that's clinically not surprising to me. When we looked at the APGAR score less than and equal to 7, there was no difference. The 5-minute one is probably more relevant anyway than the 1-minute one clinically, and there was no difference in APGAR scores less than 7 at 5 minutes. The APGAR scores less than or equal to 7 at 5 minutes, less Waterbirth babies had low APGARs at that time point. So it's, you know, kind of the opposite picture to the 1-minute APGAR, which is interesting. From RCT data, there was no difference in APGAR scores. We looked at whether they were admitted to neonatal intensive care units or special care nurseries, and there was no difference from the observational data. And probably one of the strongest findings, which came from that large study and others, was in cord pH values. So they looked at arterial and venous cord pH, which I think is, you know, it's one of the most objective outcome measures we could have. There's some subjectivity in the APGAR scores, and even admission to neonatal nursery, there's a bit of subjectivity there if people are a bit concerned about Waterbirth in general. But you can't do much a subjective interpretation of a cord pH value, and it was, as I said, a large number of babies that contributed to that study, 9,500, and there was absolutely no difference in cord pH values. So for me, that gives me a lot of confidence, really, that there's nothing, you know, happening physiologically necessarily for these babies because their APGAR scores are the same. Yes, Eva's made the comment about the 1-minute APGAR might be influenced by too high a water temperature. That's an interesting thought. We can discuss that when we go down to the practice points, I think. So hold that thought. Okay, so really the evidence, what we know from the best evidence, compared to babies born on land, babies born underwater to low-risk women were at increased risk of a low APGAR score at 1 minute and a decreased risk of a low APGAR score at 5 minutes. There were no difference seen in mortality, resuscitation, infection, admission to neonatal care, or cord pH values. So that's the foundation of evidence, really, that we're working with and moving forward from. The issue, there have been many tens of thousands of babies born underwater, obviously, and there are other studies, particularly from the UK, that really gathered them all up and looked at every single case of morbidity or mortality from Waterbirth that hadn't been able to show any difference with Waterbirth versus land birth. But the issue for a lot of the professional groups, of course, is we don't have that high level evidence. So that's why they're not feeling confident that this is a safe intervention or variation in practice. We don't have the RCTs, but you can see that it's, I don't know if we're ever going to have the RCTs. So this next level of evidence is really critical. And it's building. There's quite a lot of babies that have been born underwater. So we'll briefly look at this and not in a lot of detail. How does the baby make that adaptation to extra-uterine life? And I'm particularly just going to focus on the initiation of breathing rather than the circulatory changes that need to happen, which are quite complex. So obviously the fetus has to make a rapid physiological and biochemical adjustments to make that transition to life when they're born. And they include all their body systems, but we'll just look at the initiation of breathing because that's one of the most important to our ends here, looking at Waterbirth. So can you write in the text box, what's a mechanism that contributes to the initiation of respiration in the newborn? What starts a baby breathing when it's born? You might have to dig back in your memory to your training. Contact with oxygen or the air, temperature change, yep, great. Stimulation, good one. Yep, pressure gradients. So there's three main mechanisms. Chemical, which is chemoreceptor stimulation. We'll talk about that in a moment. You've got mechanical, where the compression of the chest wall through birth through the vagina, most usually, and the sensory stimulation. So let's look at those three in particular. So you know about the chemoreceptors that are found centrally and peripherally in the aortic arch and the carotid bodies, for example. So they respond to changes in arterial oxygen, carbon dioxide, and hydrogen. And they relay that information back to the medulla, which regulates respiration. So during birth, the fetus experiences that physiological hypoxia with a reduction in oxygen and an accumulation of carbon dioxide, and that is a trigger for respiration. So that's probably one of the most important, actually, initiating factors in that first neonatal breath, which is that accumulation of carbon dioxide that's experienced as the baby's being born, and that will stimulate the chemoreceptors and trigger that respiration. That's one of the most important mechanisms. Compression of the chest wall is another contributing mechanism. So you know that the fetal lungs have got some pulmonary fluid in them. That's expressed when they come through the vagina. That chest wall is compressed, expelling some of that fluid. There's a negative pressure there in the lungs, and then there's that recoil of the rib cage when the baby emerges from the vagina, and that assists with respiration, that first respiration. And finally, the sensory stimulation. So the baby's suddenly exposed to touch, its own sense of weight, its own movements, and the noise, the cooler temperature, the light, and you can see the reaction in babies when they're born with that Moro reflex in response to all that stimulation. So what happens when a baby's born underwater? How are those mechanisms working or not working? So the chemical stimulation, it happens in exactly the same way. So the baby is exposed to those same factors that are stimulating breathing with the chemical stimulation when they're born underwater. So the oxygenation through the placenta is beginning to diminish as the baby's born, but the flow is still there, allowing some delay in the necessity to have a breath. And you know, when you only have to feel the cord after a baby's born to feel that it's still pulsating, there's still some oxygenation there. So there's generally not a mad rush to do anything to get the baby to have breaths, because it's got some exchange happening in that first instance. The mechanical stimulation, that fluid is still expelled from the baby's mouth, and if you've been around water births, you can sometimes see the little bit of cloudiness of the water around the baby's mouth when the head's born and when the body's starting to be born. So that fluid from the lungs is still expelled. You still get that chest compression, but the baby doesn't have that breath underwater, even though the chest is recoiling. The sensory stimulation is diminished in a water birth, especially when you have a hands-off approach. So there's not as much of a temperature change. Well, it depends on the temperature of the water, I guess. There isn't the cool air, there isn't the immediate sound and light necessarily. Obviously it's a different environment, but it might not be as strong sensory stimulation as they would find on a land birth. And there is probably not so much evidence for this, but there's people hypothesize that there's this dive reflex, and the cranial nerve stimulation by receptors in the nose cause some bradycardia and peripheral vasoconstriction, just with the being more under pressure underwater. Probably more significant in cold water, but I don't know that we've really got evidence that there is a dive reflex in effect for water birth babies. So the main reason they're not inhaling water is because the mechanism for respiration, the chemical stimulation is the main one that's having some effect, and the babies are still having oxygen exchange. So let's draw on some of the evidence that we've got and our knowledge of physiology to think about what might be best for practice, because we haven't got a lot of experimental research. We don't have, for example, we raised the issue of the temperature of the water. I mean, we've barely got any research on water birth full stop, let alone the nuanced elements of water birth. So what's the best water temperature? So we haven't got a lot of evidence to go on, and we just have to draw from our knowledge of what evidence we do have, our knowledge of physiology, and our experience really to think about what might be best in practice. Okay, so given what you know, when do you think the water birth should be discouraged? What sort of women or situations would you say, look, that's just not a good idea? So you're really highlighting women that are at increased risk, and it's useful to think about why that would be. So why would we exclude someone, for example, GDM, Christine, or anybody? Why would we exclude a woman who has GDM from having a water birth? Yeah, a lot of our policies really do just focus on the lowest of the low risk, and sometimes I don't think there's necessarily good rationale for that. So I'm not sure that someone with GDM necessarily should be excluded. It'd be interesting to have some debate on that. Yeah, if they're diet controlled, then and we're not expecting that it will cause any problems in labour, I don't see why they should be. Obese women are often excluded, which is really interesting as well, because I think they can benefit a lot from the weightlessness that you can experience in water and being able to get into different positions. But of course, people have a lot of concern about getting women out of the bath should it become necessary. Yeah, shoulder dystocia could be a tricky one to manage in the water, definitely. Fetal distress is probably one of the biggest exclusion factors. So because you'll know that a fetus that's been in distress, one of its mechanisms that it will initiate really quickly after birth is that gasping, because it really does need some oxygen. So you don't want a baby who might gasp and is desperate for oxygen when it's born underwater. So there's a really clear indication that any baby that's or fetus that's experiencing fetal distress, or even potentially at risk of fetal distress, shouldn't be born underwater because it may gasp and it might need assistance with that transition to life. But otherwise, any woman, I think, who doesn't have any conditions that adversely impact on the baby's ability to make that smooth transition to life could be encouraged to have a water birth. And what sort of preparation and equipment do you think you would need for a water birth? And there are, of course, besides underwater Dopplers or Doptones, there's CTG monitoring equipment that can be used underwater. So, that's still a possibility. Yep, you've got some great items of equipment there. I might not have an exhaustive list, but these are some of the things that I thought about it. It is important to have knowledgeable caregivers, and there are a variety of workshops like this one, and sometimes clinical services run programs to prepare caregivers for waterbirth. You do need some agreed and practiced procedures for getting women out of a bath in an emergency. And I know that I think it's in the UK, they have hoists present for most water births, but I don't think they have been used very frequently. So having procedures for getting women out is really important. And it doesn't always mean pulling the plug is not always the best option. Sometimes filling the bath up to its highest so that the woman's more buoyant and you can almost float her out of the bath can be a good option, rather than pulling the plug and then you've got a slippery, wet, heavy woman that you're trying to get out of a bath. But if you've got a good protocol for mainly low risk women, then you shouldn't have need of this very often at all. Yeah, those hoists. Be interesting, Samantha, to know how often they're used, though. I would think it was very, very rarely, and they're quite expensive, so I don't know that they're a good use of money. The equipment, we've got the sieve. Someone said a net to remove any debris from the bath. So sometimes there are, bits of blood clot and feces and different bits of debris in the bath that you can remove. A hand mirror that can be submerged is really useful, so that you can look at the perineum and get some idea of how things are progressing there. A waterproof Doppler. You can certainly use a Pinards, but you don't want to have to put your head underwater to have a listen to that baby. You'd be asking the woman to float her abdomen to the top or stand up so that you could have a listen. It's a little bit more disruptive, but some women prefer that. A water thermometer is a good idea. We'll talk about the temperature, I think, in a moment. Torch, thanks, Samantha. That's a great idea. Torches are really useful, and you can reflect the light with a handheld mirror. If you put the torch into the mirror, it can reflect back and illuminate the perineum. So there's a few tricks with the torch. A bath. Babies are born into domestic baths, all the time as well, but ideally they're a bath that's large enough to submerge all of the baby at birth, because if it's only a partial submersion, there's a bit more stimulation on the baby, which you don't want, because you don't want to stimulate that breathing until the baby's out of the water. So all of the baby under the water is best. It's great if the bath is big enough to really allow the woman to change positions very easily. So kind of bust level water when she's squatting, that gives her the kind of buoyancy that she needs to be able to move around. It is really good if we've got two-sided access. That makes it a bit easier for attendants, and the ability to easily fill the bath with water. We had some baths put in our lovely birth centre, but the gauge of the pipes and the taps hasn't been big enough, and they take forever to fill, which is an absolute pain. And non-slip surfaces. So what sort of things would you like to see in practice guidelines? What do you think is important? Yeah, you've got some really great stuff there. Getting women out of the tub is important. Sanitised tub, yes, they can have a lot of nooks and crannies, can't they, if they've got sort of jets and that sort of thing. So most clinical services have standard practices for cleaning. And I think someone raised an issue of infection early on, maybe in the criteria, women with infection, and there has been a little bit of work around whether women who are GBS positive, for example, whether there's more risk to the baby. And we don't have good data on that yet, but I'd have to say the trend is towards less infection for babies. So it probably depends on what infection you're talking about, in terms of what infections the woman might have, but there might be something about the dilution in the water that actually makes babies less at risk of getting transmitted infections from the mother. Yeah, good point, Sarah. More wireless and waterproof CTG equipment, because that ends up being quite a barrier as more and more women are required to have monitoring under clinical guidelines. But and someone else made the point, relaxing of the policies. I agree. I think we apply them probably a bit too stringently, and there isn't a good rationale from excluding some of the women that are excluded. So we had the question of water temperature, which is really interesting. So there isn't any specific research evidence on what temperature is most ideal, but most studies in the Cochrane trial were between 37 and 38. And physiologically, if we think about it, if you've got a high maternal temperature, it increases fetal metabolism and oxygen consumption. So that can decrease the capacity of the fetus to sustain any hypoxia that it's got. So you wouldn't want that water to be so hot that it's increasing the woman's temperature. Women can dehydrate really quickly. You know, some women can spend 4, 5, 6, 7 hours in a bath. So bear that in mind. Particularly, you really need to hydrate somebody very well if they're spending a lot of time in the bath, and you don't want it to be too hot for the woman's sake, and also because of the effect that might have on the fetus. So I can't tell you, you know, I think someone else said quite a cool water temperature. That would be really uncomfortable for me. I'd need it to be at least 37, 38, maybe even more, to have that relaxing effect. So I think be guided by the woman's comfort, but also cognizant of how that might, if it's too hot, how that might impact on the fetus. Be aware also of the vasodilation that can be caused from the warm water, and if the woman stands up, she can certainly feel faint because of that, so just take care. Yeah, Eva, I have heard that before with the water temperature, but I don't know, we haven't specifically got evidence to say that it should be cool. I think we're just having to make best guesses and estimations based on what we know of the evidence and the physiology. So when should you get into the bath? I'll recommend that women get into the bath. Most recommendations suggest active labour, because there's concern that that buoyancy might reduce the pressure on the cervix. There is some evidence of if you've got some labour dystocia, that getting into the bath can actually improve that. We already mentioned that there's long periods in the bath, you've got to take care of dehydration. There's also theoretical concerns for waterlogged tissues impacting specifically on the perineum, and if it needs suturing. There's no evidence for that, but it's a theoretical concern. Your observations, they should be as usual. So your regular monitoring as per your normal policies. You can do vaginal examinations in the pool or the bath. You do need good long sleeve gloves, and even still they're not always as effective, you know, the ones that come right up to your armpits. So no reason to ask women to get out of the bath necessarily. Usually she can float up or get into a position where you can access her to do a vaginal exam if you need to. And you can use a mirror, as we said, to assist with your assessment, and you can be looking at the perineum and seeing what's happening there. So in terms of the birth, it is important that all of the baby is submerged when it's being born, not half and half because of that risk of stimulation. You don't want to stimulate that baby, so a hands-off approach is best, not necessarily touching the baby's head. I mean, there's no reason why the woman can't, and they very often do, but you don't want to additionally stimulate that baby. There's no rush when the baby's head's born underwater. You don't need to hurry the birth of the shoulders, just wait as normal for that next contraction and for the shoulders and the baby to be born. Usually physiological third stage goes along with a normal labour and birth, so you don't usually use an ecbolic or anything for the anterior shoulder. You usually don't need to cut the cord. Babies will often unravel, and I think there's been one or two photos here where you see that there's a bit of entwining of the cord, but it will usually unravel when the baby's born. And you don't need to rush that baby to the surface. There is anecdotal evidence for cord avulsion being a bit more common in water births, and I don't know why that would be, but I wonder whether people are rushing that baby to the surface, and you don't need to do that. You just gently bring the baby to the surface. You certainly don't need to hold it underwater, but you don't need to rush it to air either. In my experience, water birth babies do take a bit longer to breathe and to pink up, but 1 minute is actually a long time for that first APGAR, so give them that full minute. Monitor the baby in the usual way. Just have a feel of its cord or its over its heart, and you can feel that they've whether or not it's got a good heartbeat. Obviously, keep the baby's face out of the water while this is happening, and just watch the amount of tension on that cord. If the baby's got a very short cord, then keeping it out of the water can create a bit of tension on that cord. So just keep an eye on that. And keep an eye on the baby's temperature if they're spending quite a bit of time in the water. Mostly, if you keep that water temperature nice and warm after the birth, sometimes we put a cloth or a flannel that's wet over the baby and just keep that warmed. That will keep the baby at a nice temperature. The third stage, it can be difficult to monitor the blood loss, especially when you're new to water birth. So someone once told me to think about it in terms of wine. If the water turns a bit of a pinky rosé colour, then it's probably less than a couple of 100 mils worth of blood loss, depending on the size of your bath, of course, or your pool. If it's Cabernet, that deeper red, that's a bit more problematic, and if you're getting into the clarets, that very deep red, there's too much blood loss. So just keep an eye on the blood loss and the physiology of the woman. How's she looking? What's her heart rate doing? Just keep a close eye on her. And there have been theoretical concerns for water embolism when the placenta is born underwater, whether there's potentially water rushing in and becoming embolized, but becoming an embolism. But I've not seen any evidence of that. I think it's more a theoretical concern. In a physiological third stage, my experience is the placenta usually comes in about, I don't know, 15, 20 or so minutes, and sometimes it's when the woman stands up to get out of the bath that the placenta kind of plops out. So I don't know that it's any easier than a physiological land birth, but in my experience, it's never been problematic. Some of them are born into the water. As I said, often for me, when the woman stands up, I put it in a kidney dish. Obviously, you need some infection control processes and protection for staff. So we talked about those big gloves, cleaning protocols, which will often be part of your services protocols anyway. And just take care. There is some evidence that midwives have damaged their backs from caring for women in water birth. So take all the care that you need to look after yourself, and the exposure to body fluids. We talked about gloves and slipping. If there's if it's a wet environment. So those things are really important. I've just got a bit of a slideshow for you now. I'm sorry, I'm almost running out of time, but I think if you've got remaining questions, if you can pop them up or put your hand up if you want the mic, and we'll get to some questions. And in the meantime, I'll just show some slides.
Hi, Deborah, can you hear me? Hi, Deb, can you hear me?
Yeah, I can. Time
Oh,
to finish
lovely.
up. I'll
You've got
just finish.
2 minutes.
I have. Oh, I'm sorry.
Anna
Right, so
has asked, is there an increased risk of tearing? Have you found
no,
this to be true?
there's categorically not, Anna. That is a big myth that's out there, and there's absolutely no evidence from any of the studies we've looked at that there's a higher rate. And I've done some research in my own unit here with over 600 water births, and there is absolutely no difference, especially in the high grade tears.
Thank you for that. And Christine has asked, once the cord is clamped and cut, do you recommend keeping the placenta side of the cord clamped as the placenta is delivered underwater?
Um, to be honest, I have mostly only done that when the woman is out of the water. So as I said, with a physiological, it can kind of take 15, 20 minutes. And in my experience, mostly by then the women are getting out. And when she stands up, that's when the placenta kind of pops out. And I've used a kidney dish and we've gotten out of the pool and then we've done that cutting and clamping when it's well done. But I can't think what a rationale would be for keeping that side clamped necessarily. Oh, harder to control the cord, yeah. Well, I think in a physiological, you shouldn't be pulling on the cord anyway. It should be pretty much coming under the woman's own steam. Thank you. Okay. Thank you so much, everyone. I'm sorry I went to the wire and didn't leave a lot of time for discussion because I'm sure we could have had a great discussion.
Thank you so much, Deb. That was absolutely brilliant. And you have obviously sparked a lot of thought, I can tell by the chat. And I'm now going to save the chat and send it.
Okay. Thank you very much. Thank you, everyone.
Brilliant. Welcome. Oh, why isn't the chat sending? Any ideas, Deb? Oh, wait. I'll clear it. There we go. So this is the student forum. I thought there was going to be a I thought there was going to be a short presentation for us, just to give us something to look at. I will actually, do you know what I'll do? I'm going to use Deb's beginning slides to talk you through. The sound setup and everything else. Okay. So welcome to our first student cafe. It's lovely to see you all here. And I am just going to talk you through a few slides, and then hopefully we will get you talking, and hopefully some of you will speak as well. Okay. Now there are some polls. I don't think they've been set up in here. Oh wait. There we go. Okay, so you'll have seen these slides before, and hopefully most of you are most familiar with them. We would like to acknowledge the University of Lillebælt and of Denmark and the Association of Radical Midwives for their support for our conference. If you would like to set up your audio, you go to meeting and then work your way through the audio setup with it, and that would be great because it would be lovely to hear from some of you. There's a chat window, feel free to chat, and usually the chat lies through. If you'd like to give us some feedback, you click on the little man at the top and you can raise your hand if you need some help with the sound and select your setting. If you'd like to ask a question or a comment, please note it in the chat box. And if you'd like to talk, let me know and I can give you a microphone, and you can speak to everybody, which would be great. If you would like to speak, you will need to connect your microphone, and I will give you a microphone, and then you click on it on the top bar, and when it turns green, it means you are on. If we can't hear you, you can adjust your volume by clicking on the microphone symbol and increasing the microphone volume. Once you've finished talking, please disconnect your microphone. Otherwise, it just ends up as background noise. Lovely, Eva. Thank you so much. There are 2 more student cafes later on, so we would love to see you back there for those. And oh, I've got to.